Okay, these are the ankle special tests as they are listed in your orthopedics lab manual. First one is going to be the anterior drawer test. This test tests the integrity of the anterior deltoid and anterior talofib. So stabilize the distal tib fib. You can even scoot up just a little. And then grasp the calcaneus, support the foot with your forearm, and then you're going to pull straight up. So my pull is here, just on my left hand. Okay, so take it to end range. Any pain or laxity may indicate a tear in one of those ligaments. This is the posterior drawer test. Just change your hand position to right up here, right where the talus is. Biggest mistake students make is to be too far distal. And you lock your arm straight and then just push down. This tests the integrity of the the posterior deltoid and the posterior talofibular ligament. Okay, now we're going to do the varus stress test. This tests the integrity of the lateral ankle ligaments. So yeah, let's do this foot here. So we're now going to test the integrity of the anterior talofib, the calcaneofib, and the posterior talofib. So hold the foot and ankle in the same way. Dorsiflex the ankle. This test puts the posterior talofib on a stretch and then invert. So I'm doing an inversion here with dorsiflexion. I can do inversion in neutral. This tests the calcaneofibular ligament. And then I can change hand position and do inversion in plantar flexion. This tests the anterior talofibular ligament. Okay. To do the medial side, very similar. Put it in dorsiflexion. Notice how when I do dorsiflexion, I have my forearm supporting the foot. So dorsiflex and then evert. This tests the posterior deltoid. Evert in neutral. This tests the middle deltoid. And then change your hand position. Plantar flex and evert. This tests the anterior deltoid ligament. Those are the valgus and varus stress tests. The next test listed is the ankle dorsiflexion test. This is to differentiate between capsular restriction to dorsiflexion and muscular restriction. So you test the person's dorsiflexion like this, and if it's limited, you bend the knee and you see if you get more dorsiflexion. If you get more dorsiflexion, then the limitation was muscular, tightness of the gastroc. If you get the same limitation in dorsiflexion as you did when the knee was extended, then it's a capsular restriction. Muscular tightnesses get treated with soft tissue mobilization. Capsular restrictions get treated with joint mobilizations. Okay, the next two are can be done with a person prone. So lie on your stomach there. So the Homan sign is a test for deep vein thrombosis. So right here, you can bring the camera a little closer, like on top here. So they usually will have redness and swelling in the gastroc. There's usually pain with rapid dorsiflexion. Slide down here just a little bit. So if I rapidly dorsiflex, it'll elicit pain here, and it'll also be red and hot. So a lot of things will elicit pain with rapid dorsiflexion. So you want to make sure it's not just the dorsiflexion that causes pain, but also that there's tenderness to touch and it's hot and swollen in this area. If that is a positive test, you need to send them to the ER. Okay? And then the last one is the Thompson test. The Thompson test is a test for Achilles tendon tear. So you just take the gastroc muscle belly and you squeeze it. And a negative test is when the ankle moves. That means the Achilles tendon is intact. If I squeeze the gastroc and the foot does not move, then that means there's an Achilles tendon tear. This is the Thompson test. Okay, this is the joint play section of the foot and ankle lab. The first one is the talocrural joint anterior and posterior glide. You are just testing for joint mobility, and it looks very similar to the anterior and posterior drawer tests of the ankle that we previously showed. So again, distal tib fib stabilized with one hand, mobilization hand on the anterior portion of the talus, grasping the foot, and then you're going to just move posteriorly. A normal end feel would be a springy end feel. Okay, this is testing a posterior glide. To test the anterior glide, you change your hand position, support the foot with your forearm, get it in neutral, and then pull up. Again, you should feel a springy sensation that would be a normal capsular end feel. Hypomobilities post-fracture or post-injury will feel like you're hitting a brick wall. Okay? The next thing you want to check is navicular and cuboid mobility. The navicular bone is the first big bump. Here's the medial malleolus. If you go distal to the medial malleolus and then anterior, you'll feel this big bump that is the navicular. And to mobilize it, I'm going to put my mobilizing hand here on it, and my stabilizing hand just proximal, and I'm going to push this way so I can do a dorsal glide, and I'm using this first phalanx, proximal phalanx, to do it. So I can do a volar glide of the navicular, test it for that normal capsular end feel, and then you see I have it hooked here with my finger. I can pull dorsally as well to see if it moves. So that is the navicular bone. You're just gliding it volar and dorsal, plantar and dorsal, I should say. Okay, to do the cuboid, have you switch feet here. The cuboid bone, if you find the big bump on the lateral side of the foot, that is the head of the fifth metatarsal, base of the fifth metatarsal, and the cuboid bone is just proximal to it. So find the bump and then move proximal and then pinch the bone. So you can get the bone here between your index finger and thumb, and you can glide it dorsally. I'm pushing this way, and then you can pull it plantarly, pulling towards me. Okay, so that is the cuboid. While you're down here, you can check the mobility of the first and fifth ray. Grasp the foot, the second through fifth digits with one hand, and mobilize the great toe dorsal and then plantar. It should move an equal distance, about finger width distant, dorsal and plantar. And then switch your hand position and do the same thing with the fifth ray. It should move equidistant, dorsal and plantar. And then the last one we're going to do is the subtalar joint mobilization check. From here, you want to raise my stool, sorry. Okay, so from here, the axis of motion is right down here through the ankle joint. So you want to evert the ankle. So I'm stabilizing here at the distal tib fib, and I'm moving the ankle into end range here. I'm just testing the ability of the ankle to evert. About 6 to 8 degrees is normal. So it's not a ton of motion, but it should feel like a nice normal end feel. A hypomobile subtalar joint will feel like you're hitting a brick wall, and usually the patient will be able to detect that tightness as quick, or if not quicker, than you can. Okay, so this is the palpation section of the foot and ankle lab. We're going to start with palpation of the structures on the medial side. So you see the medial malleolus here. Right posterior to the medial malleolus are the tendons of Tom, Dick, and Harry, and Tom, posterior tib, is right intimate to that medial malleolus. So from here, you'll palpate posterior tib, tibial artery and nerve, and the other two tendons, flexor digitorum longus and flexor hallucis. It's difficult to differentiate outside of the posterior tib which one you're touching, so diagnosis of which one's injured will be combined with stretching those particular muscles. I'll show that another time. So medial malleolus, the tendons of Tom, Dick, and Harry here, the navicular bone here, and then there's the medial ankle ligaments. So the deltoid ligament is like a fan. The anterior deltoid is here, the mid deltoid's here, and the posterior deltoid's here. So all I do is find that medial malleolus, go anteriorly, and I can run my finger this way. So the ligament's running in this orientation, and I'm running my finger across it. The middle deltoid's in this orientation, I'm running my finger across it. So as long as you're just falling off the medial malleolus and moving your finger, you will find it. If you're too far away from the malleolus, you'll be off of it. So fall off of it, and then anteriorly, this is the anterior delt, middle delt, posterior delt over here. You can feel little bands of tissue that are those ligaments. Okay? On the lateral side, we have the lateral malleolus. Of course, we already talked about the base of the fifth metatarsal where peroneus brevis attaches, the cuboid bone right here. So we have peroneus longus and brevis that come across. Brevis attaches to the base of the fifth. Longus comes around and attaches to the base of the first. Both of them decelerate supination. So in an ankle sprain, these can be injured. You want to palpate those tendons just behind the lateral malleolus. Now the anterior talofibular ligament is right in the sinus tarsi, this divot that's just anterior to the anterior and distal to the fibula. Lateral malleolus here, you can touch it right here is anterior talofib. Work your way down underneath the fibula, and here is the calcaneofibular ligament, and then work your way around the back side, and here is the posterior talofibular ligament. All right, go on your stomach there. Obviously, the Achilles tendon is not hard to feel. Maybe you can stand up and film it down this way. So here is the Achilles tendon here. Really simple to feel. While we're back here, these are not on the list, but it's good to show. As I work my way up the leg, you'll feel the muscle belly of the soleus. These are the trigger points I was mentioning that may refer pain to the SI joint. And of course, the trigger point for the gastroc soleus is up here. The thickest part of the gastroc muscle belly, medial gastroc, lateral gastroc, coming down to the Achilles tendon. So you can palpate the Achilles tendon in the cases of tendinitis. Sometimes it's also tender and helpful to detect an injury by pinching it. Okay? And then the last thing on that list is the medial calcaneal tubercle. So if you come around here, just bend that knee here. So you can see here on the bottom of the foot, here's the calcaneus. On the medial side, kind of right where the arch ends, is this medial calcaneal tubercle. It's the point of attachment of the plantar fascia. So if someone has plantar fasciitis, it will be tender right here in this area. So that's the position of the medial calcaneal tubercle. Okay, we're on to the treatment techniques. The two mobilizations are the subtalar joint eversion and the talocrural joint posterior glide. So here's subtalar joint eversion. Foot in neutral. Grab the calcaneus. If it's her left leg, I use my left hand such that my thenar eminence is on the medial side of her calcaneus. Grasp it. The axis of motion is again here. Remember, you tested it by doing this. Here's the treatment. I keep my testing hand in the same place. I'll evert the calcaneus, and then I'll take my hand on top in a cylindrical grip and invert the forefoot. It looks like I'm wringing a towel. So it looks like this: 1, 2, 1, 2, 1, 2, just like that. The biggest mistake most students make is to have this top hand a little too distal or a little too underneath the foot. So if you find yourself doing this, you're gonna have a hard time doing the mobilization. Make sure your hand is on top and you're twisting one out, then the other one in, and then letting go of the pressure. So I'm letting go of the pressure without actually letting go of the foot. I'm not doing this, letting go of it every time. So it's evert, then invert, evert, invert, evert the rear foot, invert the forefoot. Very important mobilization. Okay, the talocrural joint posterior glide is very similar to all the other joint play techniques that we've talked about already, and the posterior drawer. Stabilize the tib fib, and then just simply drive the talus posteriorly. If you're going to do a grade 4, you push till the end of the range, and then you do a tiny oscillation. Okay, good. Now lie on your stomach. This is the correction of a posterior fibular head, the muscle energy technique. So what you want to do is you want to assess the position of the fibulas, and you want to look for which one seems posterior. It seems like this one is. You confirm it by palpating the bicep long head tendon just about an inch above. So here it seems like this right one is more posterior. If you can see it from the top, see how this right thumb is closer to the ceiling here? I can see it. Hopefully that's translating on camera. So to fix it, I'm going to come over here and I'm going to passively plantar flex and invert the foot till I feel a breath of movement under this fibula over here. So I just lay my palpating hand here, plantar flex invert, and then I'm going to have her gently push her foot out. I'll just let her push into my leg. Go ahead and push. As she pushes, I gently lean in with my body weight. 1, 2, 3, 4, 5. Relax. And again, push out. 1, 2, 3, 4, 5. Relax. And again, push out. 1, 2, 3, 4, 5. Relax. And then passively return to neutral, and then reassess the position of the fibula, and then reassess the tender point on the bicep femoris tendon. Okay, these are the mulligan techniques to improve ankle dorsiflexion and plantar flexion. To do dorsiflexion, if the restriction is detected in open chain, then you want to treat an open chain. So the restriction would feel like a pinch in the front of the ankle versus a pull in the back. Okay, if they're feeling a pinch in the front, I'm going to push into a posterior glide here while the patient actively dorsiflexes. So she's actively dorsiflexing and I'm just moving with her. If this alleviates her symptoms or makes it easier to move, I will repeat this for 6 to 10 repetitions. Again, I'm just pushing down. She's providing all the dorsiflexion movement. Okay, that is the mulligan approach for ankle dorsiflexion in open chain. I'm going to show you mobilization with movement to improve ankle plantar flexion. So bend this knee up. Now we're going to show this one. Okay, so if someone has a difficult time plantar flexing, and the way you test it is you have them go prone, and their foot should be totally flat on the table. Can you just demonstrate that so they remember? So here, with their feet on a plinth, notice how she's plantar flexed. There is no space here between the table and the front of her ankle. So if someone's lying on the table and their ankle looks like this, they have a restriction to plantar flexion, and this following technique can help. Lie your back there. So here you have the person lie down with their knee bent, and then I'm just going to apply a posterior pressure here. Notice if I push on her distal tib fib, it passively dorsiflexes the ankle. Right, so I'm going to actually push with this hand here, and then I'm going to grab the right foot with my right hand. I'm going to pull forward and then down. Pull forward and then down. I'm kind of still applying a little pressure with my left hand here as I do this mobilization 3 times. That's it, and then you recheck. Okay, this is the technique, the Mulligan approach to improve ankle dorsiflexion if the limitation is in weight bearing. So if when they squat they feel a pinch in the anterior ankle, this is when you would employ this technique. Right? What we want to do is stabilize the talus, and this time we're going to pull the distal tib fib forward while they squat. So actually do a squat, yep. So as she squats, I'm just pulling forward, and I'm just applying the forward pull of the distal tib fib, assisting while she squats. If it improves her range of motion, you do it for 6 to 10 repetitions, and then after 6 repetitions, you let go, and then you recheck the squat without the mobilization. Okay. These are the counter-strength techniques for the foot and ankle. The first one is going to be the anterior talofibular ligament, which is here. If it has been strained, it can have some tenderness on it. We want to hyper-shorten it. So first of all, you have to palpate a tender point for each of these. Here's the tender point right in the sinus tarsi. You shorten it by doing dorsiflexion and eversion. If it's in the correct position, when you poke the tender point, it will be 70% less or gone. If that's the case, you maintain this for 90 seconds. No need to keep pushing here. After 90 seconds, you will passively return to neutral. Okay? The pronatus longus and brevis tender points tend to be in the back of the lateral malleolus. And so to shorten it, you're going to plantar flex and evert. So notice how I have my hand here. It's not traversing all these joints of the foot. I'm right here, plantar flexion, eversion. If it's working, it'll diminish the tender point here just behind the lateral malleolus. Hold it for 90 seconds, passively return to neutral. Posterior tib tendon, you palpate here on the medial side. Tender point will be here. To counter-strain it, you plantar flex and invert. Hold it for 90 seconds, and then passively return to neutral. So that's plantar flexion and inversion. Okay? Lie on your stomach for me. So the medial and lateral gastroc trigger points are found right here at the medius portion of the gastrocnemius. So if I'm trying to shut down the medial gastroc, I'll first find a trigger point here, and if I want to use counterstrain, I'm going to flex the knee, adduct the tibia, internally rotate, and then plantar flex the ankle. So it's you notice this grip I have on her foot, kind of T-barring her calcaneus, so I can put a lot of pressure in plantar flexion. I'm adducting and internally rotating. I know I'm in the right position if the medial gastroc tender point is diminished or eliminated. 90 seconds here, passively return to neutral. For the lateral gastroc, the trigger point is here. I flex the knee, externally rotate, abduct, and plantar flex the foot. Notice again how my fingers are putting pressure on the calcaneus to get that plantar flexion. 90 seconds here. The biggest mistake students make with this is not to push hard enough down on the calcaneus to get plantar flexion. If you don't push hard enough, you won't shut that trigger point off. And then finally we have the plantar fascia. The trigger point tends to be here at the medial calcaneal tubercle. So how I treat it is, I'm going to get down here again, distract the calcaneus and then kind of fold the foot so I can palpate the trigger point here. Distract and fold the foot, and if that trigger point is better, I'm going to maintain this position for 90 seconds. So it's calcaneal distraction and then kind of foot flexion, if you will. Folding the foot over that tender point to shorten that area. 90 seconds. Okay. All right, finishing up the foot lab here is the transverse friction massage and the muscle spindle massage. So from prone here, you can see the Achilles tendon. Because it's a tendon, it's a paratendon. It has a tendon kind of over a tendon. I want to restore that gliding. So to do friction massage, I will put the tendon on a slight stretch by pushing on the metatarsal heads here to get into dorsiflexion. Then I'll almost kind of pinch the tendon on either side, and then I'll do this friction massage in this direction, superior, inferior, parallel to the tendon, to try to improve the blood flow. Okay, so slight stretch and then parallel, maintain it for about a minute or minute and a half. If it's the right thing to do, that tendon should start to go numb and the pain should decrease. Okay, while she's prone here, I'm going to go ahead and demonstrate the muscle spindle massage for the medial and lateral gastroc. Here's the medial gastrocnemius inhibition. When you inhibit, you pull from origin insertion in towards the muscle belly. And then here's the inhibition for the lateral gastroc. Sometimes you will inhibit one and facilitate the other one. Facilitation is going from the middle of the muscle belly and pulling out. Middle of the muscle belly and pulling out. All right, and the final technique we have to demonstrate is the friction massage, the ATF ligament here. So again, the ligaments here in the sinus tarsi. To do friction massage the ligaments, you place them on a slight stretch. So slight plantar flexion, slight inversion. Here I use a finger over finger technique, and the ligament runs this way, so I'm going to do a perpendicular or transverse friction massage. Again, moving the skin over the ligament, not your fingers over the skin, but the skin over the ligament for about a minute, 2.5 minutes. Okay, that's it. Get to practicing.